Dr. Kirklin, we are producing a history archive for the International Society of Heart and Lung Transplantation with pioneers such as yourself who are part of the evolution of the society. Thank you very much for spending some time with us.
Thank you.
You are without any doubt one of the most well-known cardiac surgeons, particularly in the area of thoracic organ transplantation and mechanical assist devices. We'll go through some of your achievements a little bit later. Let me ask you at the beginning, when you started your training as a cardiac surgeon in the late 1970s, this was an era when heart transplantation wasn't particularly successful, and lung transplantation has had no clinical success at all at the time. What made you become interested in heart transplantation despite this not so positive outlook?
Well, I was trained at the Harvard Medical School, and I did a residency at the Massachusetts General Hospital. There was no heart transplantation there. There was no interest in heart transplantation. One of the very junior members of the faculty was doing some dog transplants, which were generally unsuccessful. And I spent an additional year at Boston Children's Hospital, and there was no interest in heart transplantation there. I think this was really the end of the dark era of heart transplantation, as you indicate. So really, heart transplantation wasn't in my thinking at all. When I finished training there, there were many attractive aspects of my father's way of thinking about scientific issues and about the way they did operations at UAB. So I took some additional time there and then joined the faculty. And even during that time, heart transplantation was not really of much interest.
So how did you make it sort of your main professional focus?
Well, heart transplantation was initiated just before the cyclosporin era started by a surgeon named Bob Karp. And it was, they had done a few cases. The mortality, of course, was high. And Bob Karp left to become the director of cardiac surgery at the University of Chicago. At about that time, I had been observing the passing scene in heart transplantation, and of course it was fascinating, but I really had not had any training. There was a young, very vibrant surgeon named David McGiffin, who was about my age and had come from Australia on a Fulbright scholarship, and was actually spending time with Bob Karp. When Bob Karp decided to leave, there was a void in the institution for heart transplantation, and so we agreed together that if both of us stayed and participated in this field, that we would take on the heart transplant load. So we began in 1983. There had been a 2-year moratorium because patients were dying with the inavailability of cyclosporin. So when cyclosporin became available to us, we both began the program in 1983, which was really in the first blush of the cyclosporin era, and it grew from there.
Looking through the long list of your achievements, there seems to be a common theme since your major contributions center around outcomes research on a multi-institutional scale in heart transplantation, mechanical circulatory support in particular. In 1990, you founded CTRD, which stands for Cardiac Transplant Research Database. This multi-institutional database has been able to produce some very significant analysis in outcomes in heart transplantation. Could you take us through the development of this major project, and how do you look at it from today?
In the 1980s, my father had started what was called the Congenital Heart Surgeons Society, CHSS, which first was just a club, but then embarked on a multi-institutional aspect. From the times that I was in Boston Children's Hospital and came back to Alabama, it was always apparent that when you're in a small population center that you're going to be affected adversely by your ability to compile a huge number of cases and report on them. So I agreed with my father's notion that in order to overcome that, you need to collect information in some reliable, quality way from many institutions and combine their experience. So in the 1980s in transplantation, which I became particularly enamored with because of the fact that, for one reason, it was something that my father had never been interested in. It was after his time, and it was probably an opportunity for me to perhaps follow my own pathway. It was quite a bit of a shadow, if you understand. He was quite a pioneer. So from that aspect, transplantation was quite intriguing, even though I had an active practice in pediatric and adult cardiac surgery. But I always watched with some disappointment the fact that we didn't have enough transplant cases, or whatever the subject might be, to do that ourselves. So there was a young, brilliant statistician named David Naftel, and there was a cardiologist that I had convinced to join our heart transplant effort, because, as you know, at the time in the early 80s, typically surgeons were managing everything, and that was certainly the case at UAB. We became knowledgeable about immunosuppression, post-op care, pre-op care, and basically we would have to try to convince one of our cardiology colleagues to get involved in transplantation, which they had really no interest in. So we began that road, and Bob Borge was actually participating in a small group called the Working Group of Transplant Cardiologists that he had gone to one meeting that Les Miller had established. And so looking back at the Congenital Heart Surgeons Society and the infrastructure that we had at UAB, with a combination of what I thought was perhaps my insights and David Naftel and a cardiologist, I thought, well, this would be the art of the possible. So we set out we met one day at my office, and I said to David Naftel, you know, we could do this thing in transplantation that they've done in congenital heart disease. This could be done, and would you be willing to have a go at it? And he said, well, sure, but how are you going to convince these people that they should give you any data? So we came upon a plan that we would, and Bob Borge did not really have the expertise, but he had the connections. And of course, as you know, surgeons weren't about to get involved in this. This was a group of transplant cardiologists who were trying to find recognition, trying to get identity, because nobody really knew about heart transplant cardiologists in the early 80s. So we put together a proposal that we gave to them at one of their meetings in about 1989, and said, look, we will take on the entire financial burden of this for 2 years, and we will deliver a product to you. If you don't like it, you don't have to pay a cent, but if you like it, after 2 years, then you have to start paying us, because we can't subsidize this forever. And that really was the origins of the CTRD.
And talking about the outcomes and the results and the papers coming out of this huge collection of data, how do you look at it from today? What do you think is the impact on our daily practice today?
Well, I think the Cardiac Transplant Research Database, CTRD, which lasted for about 20 years, I think it was important. It wasn't as good as NHLBI randomized trials, but I think it was important for several reasons. One is that it began a conversation with a lot of institutions in cardiac transplantation that really weren't talking to one another in a scientific sense before that time. There really were no organized multi-institutional studies in transplantation before then, and so we had developed a degree of camaraderie among especially cardiologists, but also some surgeons, about the opportunity to collaborate, send data to some central repository, but most important, participate in writing papers that might impact their practice. I think a lot of things, as you know, that I don't need to do a study because I know it's true attitude was prevalent. And so we tended to quantify those impressions to some degree, and I think that reinforced certain beliefs about practices. But I think the major reason, contribution was that it got individuals from multiple institutions to talk to one another scientifically, to share data, to to cooperate in writing papers together that they were not accustomed to before, and I think it set the kind of environment in parallel with really what we all have in the ISHLT today, which is a little bit of a unique camaraderie, a smaller group of people that CRT was doing not under the auspices of the ISHLT, but just parallel with it as both of them, as this field was sort of expanding in the post-cyclosporin era.
On the same line, your next project was the Pediatric Heart Transplant Study Group, another very ambitious project. What do you think were the main contributions of that?
Well, we started that 3 years later. I was very interested in pediatric cardiac surgery and pediatric transplantation. And we had the infrastructure, of course, so it made it easier. There was a cardiologist named Bob Morrow, who is now at the University of Arkansas, who was at UAB at that time, and he was fascinated by these multivariable equations, by these nice nomograms that could be generated as solutions to these equations. And he was very interested in carrying the banner to his pediatric cardiology colleagues elsewhere in the United States to try and get their participation. So he was really our entree into pediatric cardiologists. As soon as they saw the results of what was happening with the CTRD, they were very, very anxious to get a similar thing started in pediatric heart transplantation. I think over the years, really, the PHTS has been even more productive than the CTRD, perhaps in part because, as you know, pediatric cardiologists that are focusing on heart failure and heart transplantation, they don't have as many patients, perhaps they don't have as many opportunities to publish. And so for them, it was especially important to sort of combine forces. And even today, that is expanded into a living, breathing foundation which has been established that we don't control, they control, the pediatric cardiologists at all these institutions control. So they have ongoing efforts to generate information, which I think really in that setting is not available anywhere else in the world, in the field of pediatric heart transplantation.
Another subject, for many years you have been working with mechanical assist devices, and when our society saw the need for a registry for this new form of therapy, you decided to put a proposal forward to set up a large multi-institutional database for VADs, supported by government agencies and national healthcare institutions. This project, established I think in 2005 as I remember, well known as the Intermax, has really helped this form of therapy to gain wider acceptance and has become a landmark for VAD users worldwide. Take us through the development of this very important project.
Well, David Naftel and I, in 2000 or so, had 10 years of experience with the CTRD and PHTS, and it was clear that there was interest in mechanical support. During Bob Cormos's presidency, he and I had a number of conversations about the importance of mechanical support for this society and the fact that we should do a registry. So that was established, and it lasted for a couple of years. It really was ill-fated. Unfortunately, there was not general enthusiasm. There was some problems really in the development of so-called Tier 1 and Tier 2 data, which was staggered, and therefore there was delays in getting useful information. And at the end of the day, the society felt that they really weren't getting their money's worth. So at about that time, with the approval of the HeartMate XVE after rematch, there was a huge interest from the federal government in exploring and perhaps controlling proliferation of devices for permanent destination therapy. And so, as you indicate, the NHLBI put out an RFP for proposals. I didn't really know about that proposal. But one day in 2005, Lynn Warner Stevenson and Bob Cormos called me and said, you know, there is this RFP. We've been talking to people within the ISHLT, and we think that we, meaning the ISHLT, should put in a proposal. And of course we agreed. we thought that there might be some issues because of the international flavor of the society versus this American initiative. But at any rate, they said, well, because you've done your work in CTRD and PHTS, you might be uniquely qualified. So we started down the road of that RFP, and which, as you know, was subsequently successful. But it was really modeled on our expertise in cardiac transplantation through those databases. And it's interesting that there were two other competitors for that grant. And although I had had a long-standing interest, as all of us interested in cardiothoracic transplantation and devices, it really was not a major part of my academic activity at that point. And in fact, when we began to put in the proposal, there were a number of competing people from other initiatives, and they called me on 2 occasions, and some of the leaders for the other competing proposals said, well, Jim, you've done a lot in transplantation, but you're not really that well known in the world of mechanical support. Why are you doing this? And of course, we answered that, well, that may be the case, but we do have the infrastructure to apply lessons from cardiac transplantation to devices, and ultimately, with the very substantial help of other members of my ISHLT, we were awarded that proposal and went forward. But it really was based on the CTRD PHTS experience.
Mm. I mean, it has achieved amazing information for all of us. What's your expectation for the future of Intermax?
Well, there has been an award for another 5 years. The NHLBI has made it clear that they are going to have progressively decreasing financial involvement, although they expect long-term oversight. So this has evolved to a required partnership between industry, hospitals, and investigators. And every indication is that with the exploding emerging devices, miniaturization of devices, and their general availability compared to transplantation, that there will be long-term interest in high-quality information. So I expect that Intermax will be preserved. My own intent would be for Intermax to have a more international, in some form, availability. As you know, Japan has developed what they call JMAX, which is modeled directly after the Intermax data fields and platform. The United Kingdom now requires a centralized repository of information about devices. And it is our hope that in some form this society will take the lead in perhaps developing a high quality, that is, some sort of database internationally, which will require a certain level of data quality, which perhaps will contrast somewhat with the transplant registry, which is whatever data is available is downloaded to UNO. So I guess that would be my dream for Intermax, that it wouldn't be called Intermax, but it would be embodied by this society, and that there would be high-quality, serious investigators worldwide, maybe not at every hospital, but at certain hospitals that wanted to participate in the process of seeking truth about devices through data sharing, but with the requirement that they have validated quality data that one can truly believe in as we move forward.
One of your many jobs working for the International Society for Heart and Lung Transplantation was the one of the editor of the Journal for Heart and Lung Transplantation in '99 when you started. I remember very well how difficult it was before you took on that job to keep the journal viable and to increase its international visibility. So please give us your view on how things have developed since then and when you took over the position as editor.
In 1998, I believe, Maria Rosa Costanzo had, because of some political situations within the society, had elected not to continue as editor for the remainder of her term. And so there was an opportunity available. I was interested in being the editor at some point. This was a little earlier than I would have liked because of the other commitments I had. We were in the process of finishing a textbook at that point, and there were a lot of other things happening at UAB. So I did put in a proposal, and I think quite honestly, it indicates that, you know, we all have to make some choices about where we put our publications, where you put your energy, and for a number of years in the previous decade, we had selectively, for better or for worse, put our material largely in the Journal of Heart and Lung Transplantation, even though, as you say, there was some, it perhaps certainly wasn't as high profile as the Journal of Thoracic and Cardiovascular Surgery or the Annals. But at any rate, we were able to persuade the board that we were quite serious about this proposal, and I became the editor. And my mission really was to increase the impact factor, to increase its national visibility, both in heart and lung transplantation, but in a major way mechanical support, and to try to further solidify this society as the home of both mechanical support as well as heart and lung transplantation. And I think with the transition during my 10 years and then now to Mandeep Mehra, I think that the journal has clearly established itself as the premier journal for heart and lung transplantation and mechanical support.
What do you think are the potential problems in the future of such a highly specialized journal?
It's a challenge, there's no question. It is a challenge. But, you know, in one respect, all of medicine and cardiothoracic surgery are moving to some extent in that direction of super specialization. There's international journals for valvular heart disease, for pediatrics, and a variety of things. And I think that actually for the society, the challenge will be not, in my opinion, not to be dissatisfied with being small. I think that the focus of this society, which has been so successful, is to try and be the very, very best in the world in three basic areas: heart and lung transplantation and mechanical support as they relate to end-stage heart and lung disease. And so I think it is very, very important to grow as much as you can, but never lose sight, and that relates specifically to the journal, never lose sight of your basic mission of those key areas of your mission that you want to be better than everybody else. And those are those areas. I think if we keep that in mind, as we keep trying to expand on the fringes of things that relate to end-stage heart and lung disease, that we can acquire those areas like pulmonary hypertension, like stem cell transplantation, like advanced heart failure, but never forget your core. Because once you get spread too thin, then other societies start invading your areas of expertise. And so I think there's this paradox that we want to get bigger, but not being real big is, in my opinion, not bad, as long as you're fulfilling the needs scientifically of the international community for those core areas that are important to you.
That connects in a way to the next question. Maybe you can comment a little bit on the historic role of the journal within the development of ISHLT.
Well, of course, it's been very, very important, and it is really perhaps going forward, the most important legacy of the society. After all, our mission is the transmission of scientific information, education, and advocacy. But those first two things are embodied more in the journal than in any other way. And certainly that our annual meeting is the showcase of that science. But the only way the national meeting lives on is through appropriately vetted scientific articles in the journal. So the journal is really the heart and soul of the society, no question.
In 2000, when you were editor, you also published a textbook in heart transplantation, and you launched a series of monographs for our society. How do you see the role of these additional activities, and do you think there is a role for textbooks in the era of the possibilities of accessing information online wherever and whenever you want?
I have to admit that I perhaps am genetically inclined toward this mission of sort of encapsulating material. I was very, very envious of my father when he was writing his textbook of cardiac surgery. And he, in his later years, of all the wonderful things that he did, you know, as you very well know, great accomplishments are somehow the intersection of not only skill but opportunity and timing. And of all those pioneering things that he did, the one activity that he stated on several occasions to me privately that gave him the greatest satisfaction was writing that textbook, and in the 2 editions that he produced. And why? Because textbooks are written all of the time, so you know, many of them, who cares? Well, he thought it was the opportunity to embrace, encapsulate information about a field or a specialty that could be refined and passed on to others in a way that would give you a level of information that you could then build on, whether it be through journals or other scientific endeavors. So I was very interested in doing the same, and the area that I had really unique experience and knowledge about, partly because of those early days of the 80s when we had to know everything about transplantation, was the book. And so along with Dave McGiffin and Jim Young, we published that book, and I must say that I was interested in the idea of having a living and breathing textbook for the society, which was the reason I began that negotiation with Elsevier about the monograph series, so that we could have small textbooks about areas that were of interest to the society that would embody all of the information, more or less, that was available at that time in that subject, and then people could build on it by reading the journal. It is challenged always by the internet and, of course, the ability to go online, but I think there is still a role for people carrying small textbooks around with them, having members of the society who are really expert in these areas discipline themselves to put together a base of knowledge in a way that they might otherwise not be stimulated to do. And a good example is this year's infectious disease monograph. It would be very unusual for the world community to be interested in a textbook of infectious disease and transplantation. They may say, well, we're interested in AIDS and acquired immunodeficiency syndromes of other types, but transplantation is too small. And so it provided a wonderful forum for that council to get experts together, contribute really state-of-the-art information that can live on as a little bit of a mini textbook, which I think otherwise would not be possible.
Because of all your contributions in the field of heart transplantation and mechanical devices and to the development of the International Society, you have been awarded to become president in 2009. How would you describe your time as a president, and what were your goals when you started, and what do you think have been your achievements?
You know, you're an ex-president, so I guess everybody has to address the question, did you have specific goals when you were elected president? And I must say I didn't. I did not have a set of goals that I really wanted to accomplish for the society. I wanted to make sure that I was managing it well, the many initiatives that were ongoing that we maintained, and of course I had some activities from the journal and the monograph series that I was interested in continuing. But I was interested in mechanical circulatory support. That was sort of given to me as a deliverable. We want you to really push that. And from the era of Bobby Robbins and Paul Corus, who really, as you know, had set into motion this new initiative and mission statement which embraced mechanical support, I wanted to push that. But you know, circumstances affect what you accomplish. So in the as you recall, in the early portion of my presidency, number one, there was a financial crisis that had gone on the year before. So we were in the midst of serious cost containment and setting up strict financial algorithms for both investing and spending in the society, and that was done jointly with Mandeep. And then the whole specter, because really one paper was inappropriately presented at the previous year's meeting, conflict of interest reared its ugly head. So I spent really 3 months as I began the presidency working with Amanda Rowe in setting down what would be the most unexciting task of embracing conflict of interest formally for the society. And of course that's not something you would never set forth as a goal, but you know, circumstances dictate sometimes what you have to do. And then, of course, the planning for the meeting in Chicago was tremendously exciting since it was the 30th anniversary. And I was terribly excited to get this history monograph together and get all of the contributions from past presidents and all of the things that went into that monograph, because I was especially interesting, and as you recall, you also made a presidential address that some presidents have elected not to do. But I wanted to get it out to the society, these revelations that had been put forth in the book as relates to its history. And so that was very exciting for me. I spent a lot of time personally putting that monograph together and preparing for that. And then, of course, we started the meeting and there was an Icelandic volcano. So once again, the emphasis was completely off the rewarding aspects, but yet in a bizarre sort of way, it was more successful than any of that because, and I remember very specifically when you arrived, and probably the only transplant VAD surgeon from England basically that made it to the meeting. I think you were one of very, very few from England, and it was such an interesting experience because the board meetings were not their usual jovial exchanges and distractions, but it was all about the business of how we were going to involve those from Europe who were not able to attend. And it was a very special, of course, special to me, but also because it was the 30th anniversary. And the way in which Amanda and the board and the entire media group of ISSLT made available within 48 hours WebEx and the interactive sessions, participation from speakers in Europe about giving their talks as if they were right there in the rooms, and going from room to room to see that it was actually happening was, I believe, one of the great unifying moments, of which there of course have been many, but one of the great unifying moments for the society in which it was very clear that those who were able to attend cared tremendously about those who could not attend, and went to really extreme lengths that fortunately were not all that difficult because of the electronic age, but went to those lengths to make sure that they could participate. And I think it left us with quite a special feeling about the meeting, that it was successful not only scientifically, but in helping formalize the international bonds that are really critical to this society.
Finally, on a more personal note, as everybody is aware, you are the son of one of the most highly recognized cardiac surgeons in the history of our specialty. How was it to grow up having such a professional giant as a father?
My father was very disciplined, very kind, but also driven. And when I grew up in the city of Rochester, Minnesota, that city was all about the Mayo Clinic and IBM. And there were many of my friends who were just automatically following in the footsteps of their fathers who were physicians at the Mayo Clinic, and I really wasn't interested in that. I was interested in athletics, and I, like all of us in medicine, were usually academically successful. When I went to college, I really chose my college because of my interest in springboard and tower diving, and I was going to be a marine biologist. But as time passed, I just could not escape perhaps the genetic interest in surgery. Not so much medicine, but surgery. And the idea, the incredible appeal of the discipline of surgery and what it can do. And so I eventually just gave into those impulses and decided to go to medical school. And when I was about a sophomore in college going into my junior year, so I had to rearrange all my courses and so on. But when I came home, my sometimes taciturn father said to me, when I said, well, I'm thinking about going to medical school. And bless his heart, he looked at me, and perhaps my background or to that date had not been one of total discipline in his mind. And he said, well, I just want you to remember one thing. If you go into medicine, you better go into medicine to be a very, very good doctor, or don't go into it at all. And that's about the only advice he ever gave me. And when I said, okay, and then I went down to Alabama, and things worked out great. But make no mistake, there is a shadow that you have to deal with. And eventually which is really something I'm grateful for. It's one of the forces that drove me into transplantation and this world that ISHD lives in, because it wasn't his world. And in fact, in 1980, more or less, he was quoted as saying, "We will not begin heart transplantation at UAB. It's not the time." After which soon Bob Karp eventually started it. But so that allowed me, perhaps in my own way early in my career, to emerge from that shadow to a degree and have my own identity, which everyone likes. So I think I attribute part of my interest in transplantation to his influence, strangely enough.
And did he sort of have significant impact on the way in your career? Like, did you liaise with him and ask him about certain advice on projects or on certain turns in your career?
He had a profound effect. We had our differences, as always as strong-willed people will have, but he had a profound effect. His discipline, his dedication, and his complete unwillingness to accept failure were things that became, whether I could succeed the way he did or not, became part of my own personal mantra. And very, very often I would seek his advice about very important turning points in one's career, that when you're facing things that aren't working out well and how you should respond. His example, as I mentioned, with his discipline in writing and his interest in multi-institutional studies were very important to me. So, yeah, he was a very profound positive influence. And eventually, you understand that there's no way that you're going to be as good as or as well thought of as a giant, as a pioneer, and that's just the way it is. And part of it relates to skill, but also part of it relates to the time in history that, we are here versus in the early days of cardiac surgery. So you just have to take those things that are available to you and do the very best you can at contributing and making things better. And so once you've realized that, then the burden is lifted off your shoulders, and it was in a different area of than his interest, so I think it all worked out fine.
Dr. Kirklin, thank you very much for your time.
Sure, thank you.